Good morning and welcome to our next session of the Region 7 Disaster Health Response Ecosystem webinar. Today's presentation is Radiation 101, Planning for Your Community. Webinar description and target audience. Our objectives are listed here. This event is accredited for one continuing hour of education. We'll provide the information for your CEUs during and after the event. We have one disclosure statement from one of our planning committees. If you have any questions, please utilize the Q&A function in your Zoom toolbar, should be at the bottom of your screen. We typically don't use the chat function during these events. We will save time at the end of the presentation for questions and answers. To access your continuing education, you will use the activity code 57236. You do have to be registered in the UNMC My Continuation portal, and I will provide this information again at the end of the webinar as well. With that said, hand it over to Frank Reuter and Angela Lake.
Mark, can you see the presentation now? Okay, hopefully you guys can see everything. Angela is having trouble. Mark, can you see the presentation?
Frank, we're seeing your slide deck. We're not seeing the main slide.
Sorry about that.
No problem.
Let me go back again. Let me go to share screen. Let me go to this one.
Perfect. That's the one, Frank.
Okay, great. Angela is having trouble connecting, so I'll probably just cover everything unless she can get some access. Anyway, the title of this is Radiation 101, Planning for Your Community. And we're going to be kind of focusing more on a dirty bomb. So the first couple slides, a few slides, are just some basic radiation information. One of the things we start off with is try to use subject matter experts in a radiological incident whenever possible. There's no single number or concentration like you can use for chemicals to put things in context. The radiation exposure doesn't manifest itself into visible injury, even at high doses. It may take a long period of time. It could take months before the manifest illness, shows up. Radiation units are very unfamiliar, very specific, not commonly used by responders, even medical professionals. So it's easier just to have the subject matter experts to, relate this information. As far as who the SMEs are available, at your hospital, nuclear medicine technologists or physicians, radiation oncology, radiology, all deal with ionizing radiation. The state radiation control program. In Nebraska, we have a radiation specialty team that consists of health physicists and physicians who are trained in radiation response. The local hazmat teams, your civil support team in your state has a lot of expertise, and a new term coming out, a ROS, a radiological operations support specialist. We're trying to create these throughout the nation to assist local jurisdictions in case of a radiological event. Okay, we're not going to go in depth as we had in previous webinars. Just once again, radioactive material, it's energetically unstable. It wants to get stable, so it releases particles, typically alpha particles and beta particles. And even after that, a lot of times it gives off gamma rays. It's giving off energy to get to a more energetic, stable configuration. So they're all different though. Alpha particles, they're big, huge, They can't go anywhere without giving up all its energy. You can stop an alpha particle with air and certainly with the dead layer of your skin. So it's not a problem externally. Obviously, though, if it gets inside, it can contribute a lot of radiation dose. Beta particles, much smaller, a little bit more penetrating. Some can't penetrate the dead layer of skin, some can. They tend to be more of a skin hazard. But once again, if they get inside, the contamination gets inside, it can contribute to an internal dose. And then gamma rays, and think of gamma rays simply as X-rays. They're almost identical, except its origin. These are typically our biggest contributor to radiation dose in most radiological incidents. And one thing to keep in mind, gamma radiation, it's just like light. As it spreads out, it loses its intensity and the radiation dose drops off significantly. So how do you get exposed to radiation? And there's three ways: external exposure, external contamination, and internal contamination. So we're going to just go ahead and play this quick little.
When a person is near a source of radiation, some type of radioactive material, he or she can be exposed to the radiation emitted by this source. However, he or she does not become contaminated. One way to think about exposure is to think about X-rays. When a person has a chest X-ray, he or she is exposed to radiation, but does not become contaminated with radioactive material. A person can reduce his or her exposure to radiation if he or she is shielded in some way from the radiation. For example, if the person is behind a concrete wall, or if the radioactive source is inside of a lead container. In order to become contaminated, radioactive material must get on the skin or clothing or inside of the body. For example, if radioactive material is incorporated into a dirty bomb, a conventional explosive such as dynamite, that has been laced with radioactive material, then people could become contaminated when the device is detonated. Radioactive material on the outside of the body is called external contamination. When a person becomes externally contaminated, simply removing the clothing can remove up to 90% of the contamination. Gently washing the skin and the hair can remove most of the remaining contamination. If a person ingests or inhales radioactive material, it can become incorporated in the organs of the body. This is called internal contamination. When a person is internally contaminated, depending on the type of radioactive material with which they were contaminated, certain medications can be administered to speed up the rate at which the radioactive material is eliminated from the body. Such medications include Prussian blue and DTPA.
Okay, so that's a good explanation of how we receive radiation dose. The other basic we want to cover is radiation dose, often referred to as exposure. The units we will use are rads or REM for gamma and beta radiation, which is typically the type of radiation we're most concerned with, a dirty bomb, and most radiological incidents. A rad is equal to a REM. We also use a much smaller unit, a millirem or MREM, which is 1/1000th of a rem. You'll also see other units called grays and sieverts. They're the SI units. They're much higher. They're 100 times. But typically, we're going to be seeing rem and millirem. So let's put dose into perspective. A chest X-ray is only about 2 millirem. A round trip flight from New York to LA due to the cosmic radiation, 5 millirem. Natural background radiation, it's around 300 millirem per year for the average American. In certain areas like Colorado, higher mineral content, higher cosmic radiation, it's more like 450. A CT with contrast is around 2 rem or 2000 millirem. Radiation workers are permitted by the government to receive 5 rem or 5,000 millirem per year. And the risk associated with that dose is comparable to what they consider safe industry, which is government office worker. As far as radiation sickness or acute radiation syndrome, you need at least 100 rem or 100,000 millirem, and you need to receive it in an acute fashion, say within minutes or hours. So there are many different types of scenarios. The ones on top, those are accidents, while the ones on the bottom, the radiological exposure device, the dirty bomb, the improvised nuclear device or nuclear bomb, those are more terrorist activities. So how many victims are we talking about? Well, in a transportation accident, to be quite honest, it depends on the accident, but most of the material is packaged according to the hazard. And so in most cases, we would expect minimal number of victims. As far as a lost source, this is an industrial radiography unit, which is used a lot in construction sites. Most times it's very often very few people, maybe just one or two. No contamination, the material is sealed. In terms of a radiological exposure device, if it was stolen or no one knew about it, it was placed in a movie theater or on a mass transit, it could take time before we realize it's an RAD event. And so we could expose a lot. Remember, there's no contamination. This is just rays coming off. Nuclear power accident, to be quite honest, very few. They have very extensive emergency planning programs. And we think that in most cases, the public would be notified to evacuate and avoid radiation dose. On the other hand, a radiological dispersion device or improvised nuclear device could be many people, thousands to hundreds of thousands of people. So we're going to kind of focus a little bit more on dirty bomb on this. And a dirty bomb is just a type of RDD where we use conventional explosives such as dynamite, and you lace it with radioactive powder or pellets. When it explodes, the blast carries the radioactive material, contaminating the surrounding area. Remember, a dirty bomb is not a nuclear explosion. The radioactive material does not enhance the explosion. We would expect very few, to be honest, if any, deaths that would be expected from acute radiological exposure. The greatest hazard is from the bomb itself, the explosiveness. However, the contamination is definitely going to hamper response efforts and could delay hospital treatment. And with a widespread contamination, you could shut down facilities and areas and have a significant psychological impact on the exposed population. As far as the radionuclides, the three main ones of concern are cesium-137, cobalt-60, iridium-92. They emit high gamma radiation and are used in large quantities in a lot of devices in medical and research, and even construction sites, as we talked with that industrial radiography unit. Cesium-137, which is shown to the right, is typically thought to be a very favorable. And the reason why, it comes in a talc, and so it's very dispersible, and you can contaminate a lot bigger area as opposed to cobalt and iridium, which are metals. So here's an example. This is just an explosion. It's a bomb that they've tested. Depending on the particle size, possibly you could have small particles entrained in the fireball going up in the smoke, while you possibly could have ballistic particles. And the explosiveness can be pretty high. For high particles, it can be greater than 1,500 miles per hour. Go to this next one.
Frank, I was able to get on, so I can take over the next slide if you'd like.
Okay, great. So now we're going to talk about the potential impact of a dirty bomb, and here's Angela.
All right, thanks. So we have a few slides here, as Frank just showed, the difference of the way the material will move depending on how the dirty bomb is constructed. If it's metallic type material, we end up with more ballistic type particles or shrapnel that could be embedded versus the cesium salt or talc type of material where it could aerosolize or be really pushed downwind. So this image that we're showing here is an example of kind of the cesium type of a scenario where it is an aerosolization and dispersal. And you can see that this is a representation of contamination. So this isn't one of the MAP products you may have seen from, you know, the protective action recommendations or anything like that. This is just purely deposition. And you can see, you know, in Omaha as an example, if there would be a dirty bomb with cesium particles released in downtown Omaha, close in, and we'll have a slide coming up to show that a little bit more in a minute, but we're going to have most of the deposition that actually results in some sort of a health concern. However, you can see that, you know, miles up the way, it's going to be, more, you know, twice background. So I know a lot of response entities and others, you know, when they see twice background, that means something in their procedure. So we have the possibility that people will be, you know, moving around in this area. There could be hospitals or other, you know, primary locations. You can see the airport is there. There's going to be the potential for contamination there, but that contamination doesn't necessarily equate to a protective action being needed, but it will equate to measurable material, which is how we end up with people coming to different locations with contamination that might be below a level that needs specifically decon. So if we go to the next slide.
Yeah, the one thing I was just going to mention too, Angela, is if you
Yeah.
look at this rectangle, this is probably where the protective actions, and this is conservative, and this arrow, this dual arrow, it's about 500 meters in width, and it goes down about 2 kilometers, and that's a conservative as far as protective actions. So we'll go to the
Yes,
next.
that's a great. So as we zoom in, as Frank noted, with the kind of recommended protective action rectangle there, that's what's recommended out of the 100-minute guidance for response to an RDD based off of a lot of scientific background and knowledge. And as we zoom in here, we're looking at now the hot zone, which is 250 meters in radius. This is where we might see some of the dose rates being 10 MR or millirem per hour or higher. And some of the explosives, if it would have been, had any sort of ballistic particles, would be within this area as well. So this is really where the zone would be set up, where responders might want to do life-saving only, critical infrastructure management only, and kind of think before they go in and do a lot of work within this hot zone area. However, outside of this area, you know, the rates would be expected to be below 10 MR per hour, and again, result in potential contamination for people arriving at your facilities. You can go to the next slide. There's 3 major points that we want to make sure that we get across. We need to get this public messaging out as soon as possible. People are going to hear that there's radiation. They're going to be worried about their impact. And as you can see, there will be a lot of areas that have measurable radiation, but the impact isn't necessarily something that needs the same sort of an attention for decontamination resources or other types of treatment resources as those close into where the detonation occurred. So we need to get public messaging out as quickly as possible to help people understand that if they were not in certain areas, that they do not need to go to the hospital, they don't need to be taking up those resources that really do need to take care of the people who were near the explosion. As Frank said earlier, the explosion is really where the actual injuries are coming from. And so if we don't want to be inundating our medical facilities or other types of facilities that need to help the people that have those life critical or other types of severe injuries. So one way we can do that is to set up community reception centers. And that is a place where the non-injured can go for decontamination, for survey to see if they are contaminated, even for just information and, you know, peace of mind, well-checked types of things. So those are really an important component to help take some of the pressure off of the hospitals. And then the medical facilities need to be prepared to kind of pivot and really try to sort through the people coming into their facility and, you know, look at procedures and see if there are ways to prioritize those injured and those that need that medical care from the facility and try to direct the others who may not need that initial treatment to one of these reception centers once they're set up. So the more quickly we can set up a community reception center to do the surveying and decontamination, the better. So next slide. So one of the good things about public messaging is there's been a lot of work done on public messaging, and the RDD guidance, again, that DHS document that's 100-minute guidance, does lay out quite a few messaging templates for us. And one of the big ones, though, that is across all of the federal agencies, and this is an example of a information diagram from CDC, is that if we can just get the message out, go inside, and stay tuned. That will help the majority of the people to go inside and to stay out of the contamination area, to pick up contamination if they haven't already, kind of stay out of the world of first responders so that they are able to get their job done without a lot of other individuals who don't need to be in the area there. Hopefully keep people out of the hospitals. But again, this is a really quick early message that's fairly straightforward for every radiation incident, is to go inside, and stay tuned. Next slide. However, the public's going to want to know more information. So there are these templates, and this is an example of one of those that's in the 100-minute guidance, but there are other documents out on the radresponder.net website. There's a resources tab at the top. You don't have to log in or anything, but it has a PIO library that's available with a lot of other template resources as well. But one of the big things that we want to do is to give people actionable guidance. So we tell people to go inside, and stay tuned. And the tuning may not happen for, some period of time. And so people are in their homes worried and thinking, I'm in here, I don't know what to do. So the more quickly we can get a message out to say, once you're inside, change your clothes, take a shower. They've kind of done their self-decon, put your clothes in a bag, put them out, on the porch. That may help those people feel like they've been able to take that action and they've been able to help protect themselves and their family, so that, again, we keep the people who need to go to the hospital going to the hospital, and those that don't home and taking care of themselves. Next slide. So again, the Community Reception Center, this is one of those kind of resources that we don't often think about, and different than a shelter or like a Red Cross type of facility that you might set up for family reunification or other types of long-term shelter. This Community Reception Center is really designed to take information on people, to survey them using portal monitors or handheld detectors that Frank will talk about here in just a little bit, to try to screen through people to see who has contamination on them and at what level it is, so we can determine whether they need to be decontaminated or potentially have internal contamination. Next slide. So these are very similar setup to what can be set up for a pod. So many of you who are in healthcare or in the public health preparedness may have a flow or a plan for setting up pod or points of dispensing. The CRC can be set up in a very similar way. One difference is that we would have a clean and a dirty, or clean and contaminated side, where we want to keep people from crossing over without being screened. We also, of course, need to have the radiation equipment available and the resources there to do the assessment and the information gathering from the individuals coming through. But there are some very helpful resources. The CDC has a planning toolkit for CRC setup and flow. There's some videos and other things like that. The Conference of Radiation Control Program Directors, in conjunction with the CDC, created a series of webinar videos that are available on YouTube that are train the trainer. So they go through how to set up a portal monitor and what are the sections of a CRC, what are some of the basic knowledge and just-in-time training that will be necessary for the individuals who will be asked to come to serve in the CRC. So one of the big things that's important for all of the healthcare coalitions and facilities and EMAs to all work together on is trying to talk through who's taking what components of this plan. There may be some logistics and the resource requests and things like that that can be handled by EMA or other types of resource requesting agencies, but the actual staffing or the decon or the registration may be handled by other entities like public health or Red Cross or other volunteer coordination groups. So this is one of the big areas that you really can make some headway in a radiation type of planning incident, is talking through this process of setting up the CRC. Next slide. I
Angela,
think
you-
we'll transition back to Frank. Yeah.
Oh, okay, I'll take over now. Okay, so we've had an event, and so let's get prepared at hospitals, medical facilities. One thing that Angela, brought up and can't, stress enough, we need to get the narrative out before someone else puts a narrative, and we need to direct non-injured, even if they're contaminated. We're talking primarily in this webinar about a dirty bomb. We're talking about a bomb. So there's going to be a lot of physically injured people. We do not need them coming to the medical facility paralyzing it. So we need to direct them to the community reception center. So the assumptions, we assume they're all radiologically contaminated when they arrive. So we need to don the proper PPE, get the personnel and the radiation equipment we can so we can monitor the victims. And we need to set up an area or a room, designate something we can say is going to be the contaminated or hot zone. So we can assume anything that goes in is contaminated until it's monitored. So obviously we're going to need a lot of bags for waste. If personnel are contaminated, you're going to maybe need to remove clothing. So you're going to have, provide some type of clothing or covering for them, whether it's scrubs or Tyvek suits or whatever. And you're going to have to go ahead and put their personal items and bag and label those. Keep in mind that it's a dirty bomb. So it could be, potentially evidence. So you need to maintain it. You just don't throw it away. And one thing I always, say, if the event like this occurred, we don't want them, there's a good chance if they're coming wherever, they could, get contamination on their feet. So if we meet them up front before they get in the facility, maybe if we have booties, we put them on so they don't spread contamination. So here at University of Nebraska Med Center, this is how we kind of set up. This is in the ambulance bay. We use stanchions and rope to kind of designate where the hot area is. And then once we go inside, this is kind of the decon room where we can go ahead and monitor and decontaminate victims if needed. As far as PPE, what you're using you're not trying to prevent external exposure. You're trying to prevent contamination. So we're all pretty used to that in the medical facility. This is one example, using a face guard and then some type of gown with usually double gloves are good in case one gets contaminated, and booties. Some places use Tyvek for decon, which is really good because the booties and the hood are usually attached and they're pretty impervious to water and chemicals. One thing I do want to mention, a lot of people think lead aprons, it's radiation, I can stop it. For the type of radionuclides we're using, lead aprons are ineffective. They're only good for low energy diagnostic x-rays like chest x-rays and CTs. There's electronic dosimeters. Now, the radiation dose coming off these patients in a dirty bomb is expected to be very, very low. However, it's good to try to monitor at least maybe one of the decon crew or triage crew just for peace of mind. The Omaha Healthcare Coalition in your radiation kits, you have 2 Radiac dosimeters and they're pretty easy to use. So when a victim arrives, you need to immediately determine if it's life-threatening. The radiation levels, once again, are expected to be very, very low. And so you need to perform all immediate life or limb-saving actions without regard to contamination. And consider all casualties that come in until verified as contaminated. So now we're going to talk about surveying and decontamination of patients for both the CRC and hospital. The basic surveying and decon methods are about the same. Most of our medical facilities in our metro area have portal monitors. These are very easy to use, to set up, and it's kind of almost like a green light, red light. They're very sensitive. They can detect down to 1 microcurie of cesium-137, which is a very small radiation dose. The only thing with our portal monitors, they're not very good at telling where the contamination is. All it says is this person's contaminated. That's where you would use survey meters, primarily Geiger counters. They're very, very sensitive, and obviously we can localize where the contamination is. So like I said, most of our medical facilities in the Omaha area have a thermoelectron, and it's made of PVC piping. We have created a step-by-step instruction to assemble a unit, and we're going to be putting it on our website probably either this week or next week. Very straightforward. The radiation detectors are in the vertical columns. This thing is kind of cumbersome to put together. It weighs 100 pounds, and each of those vertical columns is over 6 foot. So you really need at least 2 people to help assemble it, but it's fairly straightforward to assemble. We also have provided a procedure on how do you function check it to make sure it's working properly. And what it boils down to is you get a button source. It's a cesium-137, 1 microcurie, very small. And when you get everything set up, what it primarily involves is walking through the portal monitor at various levels, you know, at your head level, at belt level, and at your feet, and making sure it alarms. Now, the portal monitors, like I said, quick determination, is this person contaminated? It doesn't say on our portal monitors where the contamination is. And so that's where you need a survey meter. In most radiological situations, a survey meter equipped with a Geiger-Müller or Geiger counter or GM probe is what we're going to use, because they're very sensitive to both beta and gamma radiation. You will have one in your radiation response kit. If you have a nuclear medicine department, you're almost guaranteed to have one as well. So let's look what's in your kit. The top 2 are survey meters. They're identical, except one has a cesium-137 check source. That's for the GM meter. You have the electronic dosimeters, which we maybe talk about later. You have an alpha probe, which is really only used for alpha radiation. Okay, so it's a very specialized. In most situations, we're going to be using the GM pancake probe. So as with the portal monitor, we've created some guidance on how to use this equipment, all the equipment in your radiation kit. And we're in the process of creating short little videos that should be online next week.
Next, we're going to do a function check. If there is a cover on the pancake probe, take it off. Then place the probe against the cesium button source. You may need to move the scale selector for the needle to be on the right scale.
And that's a little snippet. Like I said, we're making one for portal monitors, for your alpha probe, electronic dosimeters. So let's talk about the survey meter. It's very easy to use. I took the handle off. These have handles so you can hold on to them, but I want you to see the face. If we start at the top, we're going to be using the top scale. That's CPM, counts per minute. That's a measure of activity. And keep in mind that the K stands for 1,000. So the 1K stands for 1,000. As I go clockwise, there's a BNC connector for the cable that's easy to connect the meter to the probe. And then we go down to the scale selector. And what you do on that one is whatever the scale's at, you multiply the needle reading by it to get the true reading. So if it's at 1K and I have times 100, that means it's 100,000 counts per minute. On the left side, if we start on top, we want to set it on fast response. Slow response gets more accurate, but it takes about 20 seconds to equilibrate. For audio, the click, click, click sound that you guys are familiar with, Geiger counters, we want to set that off. Some meters have headsets you can wear, So it's very useful to hear the click, 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 but we don't want to alarm the patients. There's a battery button. This is what we use for battery test. And then there's a battery compartment. It only uses 2 D batteries. So to use a survey meter, before you use it, you just have to do 3 simple things. Make sure it's calibrated, and that's shown on this screen. Almost all these meters are going to have some type of calibration sticker either on the side or on the bottom of them. Make sure it's not past the due date. For emergency equipment, sometimes they'll indicate when it was calibrated. And if it's within 2 years, go ahead and use it, especially if it passes the source check, which we'll talk about that. After you do that, we do a battery test, and then we do a source check. So the battery test is very simple too. For these type of meters we have, you need to switch the scale selector to anything, times 1,000, anything. And then just press down the button, make sure it goes into the BAT test. If it doesn't, just replace the batteries. Very simple. Then we have to do a source check to make sure it's responding properly. If you have a cap on your probe, just remove it and then place it right on the cesium button source. Now you'll probably have to move the scale selector so you hit the right scale that the needle falls on. And then the calibration sticker will indicate what the source should read. So in this case, we look at it, we're at times 100, it's at about 1K. So that means that 100,000 counts per minute. And if we look down at the calibration sticker, it says it should be between 80,000 and 120,000. So we're ready to go. One other tidbit, just to prevent contamination. So a lot of people take saran wrap or some type of plastic and wrap the probe. So in case it does get contaminated, you can just easily, replace the plastic. So the contamination action level, we're ready to go. First, what you need to do is measure background. In most cases, you're going to have to go to the times 0.1 scale, and you're going to find that it's typically around 40, 60 counts per minute, pretty low. If it's really high, you may need to move a different area. The contamination action level that we're using is 1,000 or 1K counts per minute above background. In many cases, when they come to the hospital, we're expecting the background to be low if we're not in the immediate area. And so a simple way, we're going to make it simple. If the background is low, less than 200 counts per minute, just move the scale selector to the ×1, and anything that's above the 1K, we're going to assume is contaminated. So how do we survey a patient? Well, you just place the probe near the surface without touching it, try to get it under an inch, and you just systematically, go from the top to the bottom, and you do front and back. The scanning speed is about 1 to 2 inches per second. If you have a lot of people, you may need to speed it up. You need to take particular attention to open wounds in the face, because if those are contaminated, that could be indicative of internal contamination. And you also need to do the hands and feet because they're likely to be contaminated. So as I indicated, if you do see high contamination around the nose in particular, or wounds, you potentially could have internal contamination, which is a lot more problematic to remove. And so what we would probably contact the radiation special team or a radiation specialist. What we would probably have you do is swab each nostril and probably take a urine sample, because that's how the best way we can to determine if there's internal contamination and how much. Now, it may become apparent that there's contamination all over this patient. And so what you would maybe do is remove clothing. In these RDD events, it's estimated that over 90% of the contamination can be removed just by removing the clothing. Now, with a large group, you may be pressed, and so you may need to speed up monitoring. You might just limit it to the, face, hands, and feet, which is the most likely areas to be contaminated. So let's talk about decontamination of radioactive material. Very similar to chemical, with a couple exceptions. Chemical decontamination, you need to do it immediately, right? You've got acid on skin, it's corrosive, you need to remove it. Radiological decon is not as urgent. The detriment takes a while, especially on skin to, to manifest itself. So you can take your time to a bit, okay? Now, unlike chemicals, you can't neutralize it. So what you need to do is physically move it. And so what we typically do is use water. But remember, when you're using water or wipes or anything, you're creating contaminated material as well. So how do we decon? The priority is wounds. And if it does have shrapnel, you can go ahead and remove the shrapnel. Be sure to keep it, not only for evidence, but for dose reconstruction, the nose and mouth, and then the intact skin. And all involve basically water. Okay, intact skin can be decon with tepid water with gentle scrubbing. Baby wipes are excellent. And if you don't have anything, or you're just creating too much water or something like that, dry decon with a clean rag can be effective. The rule of thumb is you go ahead and you try to decon with water. If it's past 3 attempts, you quit, it's fixed, it's not going anywhere. If it's a wound, you go ahead and you just bandage it up to prevent any more contamination. Now, suppose there's internal contamination. Suppose we go ahead and do a nasal swipe or urine and we find radioactivity. One thing is we do have the capabilities here at the Med Center to determine how much contamination, how much dose, what the radionuclide is. And if internal contamination is found, there are many different agents we can use, chelating agents, blocking agents. It just depends. It solely depends on the radionuclide. For example, over to the right, Prussian blue, that's what's typically used for as a chelating agent for cesium-137. So what about the waste? Okay, you're going to need a lot of bags. Contaminated clothing and personal items that are contaminated should be bagged and labeled separately, and maybe, like I indicated before, may be considered evidence. Other waste generated should be bagged and labeled, considered contaminated until monitored and proven otherwise. Now, one thing is about water, because in these situations, you're generating a lot of water. If you have a tank that you can, that the wash water is going to, and you can isolate it and you can pump it out, great. The guidance, the 100 minutes after RDD says, if you can contain it, great, but if you can't, do not waste effort in trying to contain it. Let it go to the sanitary sewer. So the steps to protect yourself, standard precautions that you guys are used to, the same PPE and donning that you're used to is also protect you from radioactive contamination. Never delay critical care because a patient is radiologically contaminated. Get your SMEs at your facility. If you have radiation safety or nuke med or rad oncology, they can certainly help. Radioactive contamination, the best way is use tepid water, maybe a mild soap, mild scrubbing certainly. Bag items which cannot be washed, and after it's all done, radiation safety or nuke med can survey the room for residual contamination, release it. There are a lot of resources out there. REACTS is out of Oak Ridge. They're staffed 24/7 as far as medical, how would I medically treat a radiologically contaminated internally or externally individual. Some of the websites, in particular, RITN and REMM, which is the Radiological Emergency Management website, has some great videos and guidance as well. So with that, that's the end of the presentation. So we're open to questions if there are any.
Yeah, I've been answering a few of them throughout your portion of the talk here. So hopefully that's answered the questions, but anybody feel free to type anything additional in, or in the Q&A, we'll definitely talk through that. So I know hopefully you were all able to see that, but you know, one of the questions was, we'll probably have more walking worried than injured as a question. And for a radiological dispersal device, that's likely true. There was a situation back in the 80s in Goiânia, Brazil, where it wasn't a dispersal device, but it was some scrap individuals who were looking for scrap material to sell, came across this teletherapy source that had cesium in it. Their family got significant doses because they took it home and you know, kind of spread it on things and ate food with it contaminated, and so they had some internal contamination. But there were only 4 deaths and about 200 people with contamination that needed decontaminating, and there were 120,000 people that wanted to be surveyed. So that was before social media and before all of the information that travels as quickly as it does now. So definitely think that that is a big component of particularly a radiological dispersal device, because that's really the goal, is to, you know, the amount of injury from the radiation on a radiological dispersal device is not significant unless you're right near the blast scene. It really is more of a public concern and a terrorist mind. I did give the link for the PIO library, and hopefully the information that Frank gave for the question about EMAs and public health getting screening equipment and training. As Frank mentioned, some of the just-in-time training's underway, and like he said, it'll be posted and videos will be made. As far as the equipment itself, I would say, you know, feel free to reach out to your EMA, to your healthcare coalition, to your radiation control program, or others within your jurisdictions to see who is able to kind of help you with that selection of equipment, the management of the equipment, and, you know, make sure it's kind of allocated across your regional area, whether that's a coalition or an EMA, you know, in kind of a systematic way, and everybody knows who has what pieces of equipment, so we can easily share in times of an issue or an incident. Seeing a couple of other questions come in. So one question, Frank, I'll let you take. Can you go over how CRC screens people? So probably just kind of walk through from the portal.
Well, it's the same way. If they have portals, first of all, here, Douglas County Public Health has stepped up and said that they'll be the parties setting up the CRC, wherever that is, right? It's going to be incident dependent. And so hopefully what they would do is, I know NEMA's got some portal monitors, get portal monitors, because you're going to have to process, like you indicated, we're going to have a lot of worried well, we're going to have a lot of people needing screening. Portal monitors are by far our best bet. You can use a survey meter. It takes several minutes, as you can tell, to really properly monitor someone. So you would set it up, maybe you'd set up a Baxter arena or something, because what you'd want, obviously, is a portal monitor. Are you clean? Are you not clean? And if you're not clean, depending on the number of people, can you survey them, or you just send them right to the showers, literally? So we're really looking, and we'll probably be working with Douglas County Public Health as far as how to set this up, how to staff it. Because we're talking, as someone indicated in the questions, we're probably going to have a lot more worried well by far than actually people who are contaminated. So I don't know if that's answering the question, but it's going to be the same way how we do the hospitals.
Yeah, and I think too, the contamination thresholds, whether they're clean or dirty or contaminated, is really going to be dependent on that number that gets selected by the authority for your jurisdiction. So that could be your radiation control program, it could be your kind of governor's representative for the state, it could be, various decision makers who decide what that number is. And it varies, across different jurisdictions. In some nuclear power plant jurisdictions, that number is 350 counts per minute above background. In other areas and guidance, it's 1,000 counts per minute, and it can go up to 10,000 counts per minute. And really that is kind of helping to manage, because imagine if you have a lot of people lined up outside of your CRC and it's hot or it's cold or it's raining or there's other human issues that are going on. If it takes really long time to look for a little bit of radiation, that's, we have to weigh that with the other risks of the incident. So that portal is kind of the initial screening, and then they get directed one way or the other, depending on whether they hit that threshold or not. And then pretty much after they've either gone through the decon and are determined clean, or they were determined clean at the portal monitor, they'll get registered. So registration is kind of that last step where we take their name and information, and we can follow up with dose reconstruction or just general follow-up for tracking in the future. If for some reason they go to decon and they can't be fully deconned, or we think that there's internal contamination, some community reception centers will set up actual screening, another stage where they'll take some of the samples like the nasal swabs and things like that. Other CRCs are not prepared to staff for that, so they'll send those individuals to the hospital for that further analysis, whether it's right then or they take their name and information and follow up with them later. So there's various ways to kind of handle that post-decon, maybe internally contaminated. And so working through your jurisdiction, resources, availability of staffing and equipment and the facility size all feed into that.
Well, once again, and we can't stress enough, public messaging, getting out, because, one of the first messages will be get inside. If you think you're contaminated at all, go ahead, remove your clothing, take a shower, put your clothing in a bag, and try to get that out. Certainly, because it's going to take a while to set up the CRC and then staff it as well.
So it looks like there's a few more questions. One is, to which site will the just-in-time training data be posted? I think it will be onto our Region 7 Disaster Healthcare Response Ecosystem website. So we'll definitely send the link out to this list and this distribution so you'll know where those videos are being posted. Another one is, what are your thoughts about the emergency department staff needing to wear dosimeters? Even if the expected dose is minimal, would it help ease the staff's ease of mind, or should messaging be that it's not necessary? So fundamentally, the theory here is that there should be some way, if you think that there's contamination being brought in or exposure potential for the staff at the hospital or a CRC, that there is some attempt to try to track dose. And it will get easier as the incident goes forward. As right away though, in the first hours, minutes or hours, we may not have enough dosimeters, or so there's kind of the live ones that will show you a dose rate and an accumulated dose. And then there are the ones that the hospital staff usually wear that don't show you a number and you have to read them through a machine. There's probably likely not going to be enough of those to give to everybody right away, but we can make resource requests and we can get that stuff to the facilities. So there could be ways that you can use the equipment that you have to do what's called area dosimetry, where you can set up one of the devices, so maybe you only have one or two, in two of the areas where you think most of the contamination or most of the exposure might occur. Put those in those locations, and then everybody that worked in that location would be kind of being tracked that way. And so I do think that it is nice, it's good to have the ability to at least know what was happening in the area. And as you can get more resources to the location, you can take that on. And that's kind of going to the second question here, as kind of confused about how they would be aware that a radiological agent has been dispersed. Since as a 911 responder, when we arrive at the incident, perhaps a bombing, we would care for the wounded and may not realize there's a radiological issue until after getting them to the hospital. And that's very possibly the case. The recommended way of kind of managing that is, if any explosion, first responders can have what's called personal radiation detectors, or little mini radiacs or PRDs. They were the little, I think they were yellow devices on Frank's picture or the slide. If for any explosion or any type of an incident, a responder turns those on, those would start to respond as you would go to the scene. So you don't have to do a lot of analysis of the scene. So even if they're going off, you have the awareness there is a radiological incident. And the 100-minute guidance kind of goes through the response and the recognition that there's a radiation incident. And so, kind of looking through that DHS 100-minute guidance document is helpful, at least for a first responder side of the fence, and knowing that you're going in. Now, for a radiological dispersal device, if you happen to be on scene and you're doing life-saving, it's very unlikely that you are going to receive any sort of exposure to any of the contamination in the area, or even what the patient brings with them as you're taking them to the hospital or wherever you're taking them. So that is should not be a concern. So even if you do have a meter on, or there's a question about radiation, for a radiological dispersal device, for sure, you should go in and do life-saving actions, using normal kind of contamination control that you would use for a biological or a chemical that you wouldn't want to spread everywhere as well. So that's really the primary goal there, is to the radiation exposure is the lowest priority. And there's a video, we can send that link out as well. The 100-minute guidance was built into videos that are out on YouTube as well. And it walks through some little bubbles above the responders' heads where it shows the dose rate. And in some cases, they're really high, like 10 R per hour or 30 R per hour. But right below there, it shows what the accumulation of dose would have been for a responder that went in to get a patient and then take them out to the hospital. So that is a really helpful video to see how even a really high dose rate can result in fairly low doses that you actually receive, because it's like a speedometer, where if you drive 100 miles an hour, but you drive for 1 minute, you don't drive 100 miles. So it's the same thing with radiation dose. You can be having 100 R per hour, but if you stay there for a minute, or if you stay there for an hour, you're going to get 100. But if you stay there some fraction of time less than that, you're going to get less. So there's kind of a good video that goes through that. So there's a question about where do we acquire portal monitors and what would be the cost. We only have one Band-Aid station in the hospital in the county. So Frank, you want to kind of address that a little bit?
Well, most of the portal monitors that we have were from a Homeland Defense grant after 9/11, believe it or not. So the best place to get one, if you wanted to buy one, there's a couple companies out there. Ludlam makes a very good one. That's what Nebraska Emergency Management Agency uses. Easy to set up, easy to use. That's where you could get one. The other thing is, I guess, with the Healthcare Coalition, is we do have UNMC has like some MOUs with the nuclear power plants where potentially we could get their portal monitors that they use for their reception centers in case there's a nuclear plant incident or something like that. They're expensive. I haven't looked at one lately. Definitely greater than $10,000. But I don't know if we can look at grants or something to try to get more. We need more. It's going to be a matter of we have tried to put together a list of all the equipment that's kind of in this area. So we do know who has portal monitors in this metro area. And I'm also kind of aware of some outside the metro area that maybe we can reach upon.
Well,
Yeah, and
Frank,
I think that.
Oh, sorry. Go ahead, Angela. Finish. I'm sorry.
Well, I was going to say that I think that lends to the planning and the coordination that can occur with a lot of the annex work that's happening here this year. Is not everyone needs a portal monitor necessarily, but if your facility might be one of those that's going to be getting the influx of people that do need to be surveyed really quickly, as far as large volumes, knowing where the cache of them are is an important piece, so that you can quickly call for them. So you don't have to have 10 at each facility. You can have two at each facility and get everybody, over to the central CRC or something like that. But each location, and I know there's people from outside of our region even probably listening in here. So I would recommend that you talk to your emergency manager about the resource request, talk to any of your calibration locations that you use to calibrate your equipment, talk to some of your other reach back, like the Radiological Assistance Program, some of the CST, other locations on radiation equipment and things like that. So go ahead, Mark.
Well, Angela, Frank, we're at the top of the hour, so we have to plan a part 2 of this topic because we still have a plethora of questions that weren't answered live. I'm going to assure everyone that we will get those questions answered to Frank and Angela. We'll include those in the transcripts as well. So I do appreciate everyone's time. Make sure that you claim your CME, and that is the portal link and the access number for our event. And with that said, Frank, Angela, thank you very much. It's an awesome topic. It makes me nervous every time I listen to you present material, but it's obviously well received, and there's a clamor for more, it sounds like. So
Thank you.
Thank you.